Good evening, Rohana sir. Hello.
Hi. Anyhow,
Hi, Shweta.
Hello, ma'am. Good evening. Good evening, Dr. Rohana. Good evening, Dr. Base.
Good evening, Shahala. Good evening, Harshal.
Good evening, Rohana sir.
Good evening. Good evening.
How is everything in Sri Lanka, Dr. Rohana? Weather is okay? Weather is good?
Weather is okay. Only thing is the environment is a little bit still there are certain difficulties, but things are moving.
Yeah, I read your email about that our Silver Jubilee conference. So
yeah.
I'm just collecting people, more and more people to come to Sri Lanka.
Yes, certainly. I mean, your support is very appreciated because I think we should celebrate it nicely because it's a silver jubilee of the SAFOG. Yes. Yeah. So I suppose everyone should cooperate, and we are meeting after a long time, all these 7 countries.
Yes.
So that is also another good opportunity.
Dr. Lee has also joined.
Good.
Oh, hello.
Hi, Raymond.
It's a Cha. Hello.
Hi, Dr. Lee.
Hi.
Welcome to our
nice to
platform.
Meet you. Nice hello, Rohana.
Hi, Raymond. Hi, Raymond.
Good to see you. Yeah.
You have joined the SAFOG, not the FOG.
Yeah. Yeah. Because I miss you, Dr. Rohana. Yeah.
So I think that's why you have resigned from FOG.
Yeah, but I miss you, so
so you're here.
On this channel club. Yeah.
So Shweta, we are very much on time. Can we start?
Okay. Arshil?
There is a countdown or something, yeah?
5 o'clock.
Mr. Sudeep, should we start?
Yeah, just I'll make it live now. 3, 2, 1. Slide now.
I shall unmute.
I'm sorry. Good evening, everyone. I hope everyone had a great Sunday today. Today we are actually starting with a general club organized by Imaging Science Society, the SAFOG initiative. For this, I will invite a coordinator, Dr. Shweta Kaul Jha ma'am. Dr. Shweta Kaul Jha ma'am, the director of Nirmaya IVF Center. I'm an MS FNB Reproductive Medicine, board certified fertility and IVF specialist, 70 years of experience and 10 years post FNB. Ma'am is the currently treasurer of IOGS, managing committee, a member of IOGS, executive member of MPSR, reviewer general of obstetric and gynec, editor of co-manual of infertility ASCOG 2022, workshop convener. Member is a contributor of various chapters, articles, and papers at national levels. Ma'am, I received a Chikitsa Ratan Awards for social work. I welcome you, ma'am.
Thank you, Harshal, for the kind introduction. Good evening, everybody. I am Dr. Shweta Kaul Jha, the coordinator for this program. And I'm so thankful that everybody has joined and on time. Without wasting much time, I will introduce and welcome. It is our proud pleasure and pride to have with us Dr. Archana Base ma'am, whose brainchild is this journal club. She is MS DNB FRCOG. She is Vice President FOXY 2020, Organizing Secretary AICOG 2021, Managing Committee Member ISAR, Fellow Representative AICC RCOG West Zone, Managing Committee Member IAGE, Managing Council Member ICOG, Past President Indore Ops and Gyne Society, Chairperson FOXY Imaging Science Society, Founder Secretary MPSR, and Organizing Secretary ISAR 2016. I welcome Archana ma'am. Please take over.
Good evening, everyone. And I welcome you all on this platform of Imaging Science Committee SAFOG. At the outset, I would like to thank our Professor Dr. Rohana for giving us liberty to hold this journal club. I think it was a SAFOG's vision to really involve the young gynecologist with the SAFOG. And that gave me an idea, why not to come up with a journal club? Because, with the journal club, we can invite many of the young doctors on this platform. And for all to know, I acknowledge presence of a writer of the article, Dr. Lee, also here, who has enthusiastically said, yes, I will come here. Let me tell you what happens. What we are practicing today in clinical practice is basically based on the research and the lot of work done by the researchers and the papers published and the evidences, because in the modern time you have to do an evidence-based practice, and evidences are by the hard work and the efforts put by the researchers. So I mean, basically we have a very good 2 hours program where the young people like Dr. Shweta Kolja and Dr. Dimi Modisha will be presenting their papers. And we have mentors also, Dr. Shahala, Dr. Meenu Agrawal, who are managing committee members along with me at SAFOG, and Dr. Atit Kundal, who is also committee chair, has agreed to share the chair person for this program. And I am really indebted to Professor Dr. Rohana for present today on this Sunday. In spite of his busy schedule, he said, I will be there, and he was dot on time. He is our guest of honor today. Can I have his CV, Dr. Shweta? He is founder chairman of Ninewell Care Hospital, Colombo, Secretary General AOFOG. He is immediate past chairperson, Menstrual Disorder Committee, FIGO. He is president SAFOG, President South Asia Federation of Obstetrics, Menopause Society, President World Gestosis Organization. He's past President Sri Lanka College Obstetrician and Gynecologist, past President Menopause Society of Sri Lanka, Treasurer Asia Pacific Society for Infection in Gynecology and Obstetrics 2010 till date. I think once he was there in our program, and he said that technology should reach to everyone, and especially in the SAFOG region. What we are looking is that there has to be an expansion and infiltration of the technology and research into all the strata of this society. So I present to you Professor Rohana for his blessings to our program.
Thank you, Dr. Archana, for that kind words of introduction. So I'm very thankful to you as the SAFOG committee chair in the Imaging Sciences Committee. I know and I have seen the amount of work you had done in the FOGSI as I think the Imaging Committee chair in that. So I also had the opportunity to be in some of your programs. And so I know the amount of work you have been doing, how you have been spreading knowledge to so many areas in India as well as outside India. So this is also one of your brainchild, this journal club. As you said, this will reach our younger gynecologists. So that is something which we also want as the SAFOG office bearers, the executive board is really interested in getting these younger members involved in SAFOG activities, because we know that they are the ones who will carry forward these activities of the Federation. So we need them to participate in our programs. So I really congratulate Dr. Archana Vasa for this initiative of having this journal club and getting so many into this first program itself. And I am happy to see Dr. Raymond here. I mean, he was in the AFOG as the committee chair in the reproductive REI and in endocrinology and infertility committee. I mean, he's an excellent worker. He has done so much of programs to us in the region. as the chair in this committee. So his presence will also add to this discussion very much today. So today in the morning, the SAFOG, we had a webinar on evidence-based medicine. So that showed the value of evidence-based medicine. So how evidence-based medicine can be used into our practice. So it is not only the evidence-based medicine that will decide on the treatment methods, but still evidence-based medicine plays a very important role in our day-to-day practice. So this type of journal clubs will help us in improving our knowledge in this regard. So without taking any more time of yours, because there is so much to discuss and learn from you, so I will wish this journal club all the success. So this is only the initial meeting, and I'm sure you will have monthly meetings to continue, and I am sure that this will catch up and everyone will more and more will join this journal club meetings in the future. So thank you very much once again. Thank you.
Thank you, Professor Rohana, for the kind words and blessings. I think these are kind of the meetings will pave a path for our youngsters to come forward. And I mean, Dr. Lee will tell that how really they can, get involved in paper writing and how they can be involved with the journal clubs. Just discussion, how it will improve our outlook towards any problem. So thank you very much. And now I will hand over to Master of Ceremony, Dr. Harshal Shah. Is Professor Yusuf Latif also has joined Shweta?
Doesn't look like.
Okay, so we move ahead and we'll look for him. If he's around, then we'll introduce him and get him to speak to us. So Harshal, please take over and let Shweta do her presentation. So you can just give a topic of Shweta here. Yeah. And Dr. Atit Kundal's CV, if we have, yeah.
Thank you, ma'am.
Yeah, so just introduce Dr. Atit and
yes,
call him on the dais.
Yes, ma'am. I would like to introduce our chairperson of first session, Dr. Atit Kundal. Sir has done MBBS and MD, fellowship in urogynecology, senior consultant of obstetric gynecology at Government of Nepal. Sir is an executive member in Nepal Society and Gynecology. Sir is a life member of Nepal Medical Association and Nepal Society of Obstetric Gynec. I welcome you, sir, and welcome you to chair this session. Along with that, I think so, Sir has not joined yet. Along with that, I will now invite the mentor of this session, Dr. Minu Agrawal, ma'am. Dr. Minu Agrawal is the National Director of Clinical Board of Morpheus IVF Chairperson, Imaging Society members, FOXY 1821, elected Executive Board member of Asia International Society of Gynecology Endoscopy Courses, Director of International Training Courses in UAE and American University of Sharjah, visiting consultant at JTS Medical Center, Dubai, UAE. Ma'am has more than 10 publications in international journals, authored 4 books as an author of Bachelor in Reproductive Surgeries. And ma'am has many awards like India's Greatest Leader by Asia 1, Iconic of Health by Times India, Inspiring Gynecologists of West India by Health World, and Champions of Foxy by Foxy. Welcome, ma'am, and I wish to mentor you at this session. Now I will like to invite the speaker, Dr. Shweta Kaul Jha, ma'am. And please, dice yours.
Okay. Mr. Sudeep, I would like to share my screen now.
Sure, madam. Go ahead.
One second. Okay. My slides are visible?
Yes.
Yes. Okay. thank you, everybody, and let's get on the business. I'm really happy, lucky, and feeling very excited because Dr. Lee is here, and I mean, we are just floored by your humbleness, sir, that you accepted our invite just on a mail, and you are here. And I am feeling that I have to just read the slides and rest. I think you are the one who has to guide us about it. Okay, so this is the study which was published in, I'll just reduce this. This was published in the journal of Ultrasound Obstetric Gynecol 2020. It was published online on 10 February 2020. The topic of the study is comparison of antral follicle count and serum AMH for determination of gonadotropin dosing in IVF. It is a randomized trial. And the first author, Dr. Raymond Lee, is with us. So if we look at the journal, if we critically appraise the journal, it is ICOG's official journal, and it is also known as White Journal. It is a peer-reviewed journal. It has an impressive impact factor of 7.3 with more than 5 million article downloads each year. It is published monthly and features a completely international authorship and fully electronic manuscript submission and review process. It is incorporated in all the major abstracts and indexing databases. So this was about the journal. It is a very reputed journal. Now, if we see at the critical appraisal of title, so whether this title addresses our PICO, that we need to see. So it is addressing about the population being studied, intervention, that is either the AFC is taken into account or the anti-mullerian hormone. Control is one of the intervention. Control comparison is there, but outcome is not mentioned in the title. So this is this thing is not mentioned in the title. Otherwise, it is quite a declarative title. So I'll just note few points which we can ask sir later on. And if I look at the authorship, it has 8 authors. So what we study is like in case of more than 7 authors, each and everyone's contribution need to be written, like how they have contributed. So I thought that part was missing in the description later. It is a randomized control trial. It is a double-blind study which was conducted at the Department of Obs and Gynae, University of Hong Kong, Queen Mary Hospital. So this is a tertiary university affiliated hospital. So they have specified the people involved, the clinician involved, and the hospital involved. That description they have given rightly. Now, when we are critically appraising a RCT, there are certain tools which are available online, and one of the program is using the consort guidelines. So we will see this RCT whether it has it is as per the consort guidelines or not. So these consort guidelines, they are available on net, and this is the flow diagram which we will assess whether this RCT is as per this flow diagram, and the checklist. So this checklist is there, like in title abstract, we need to see the identification of randomized trial in the title, structured summary of trial design, method, result, conclusion. In introduction, do we get the background and objectives clear? In methods, have they told about the trial design or important changes to method after trial commencement? Participant, what was the eligibility criteria, setting, location where the data was collected? Interventions for each group with sufficient details to allow replication, and the outcomes completely defined, pre-specified primary and secondary outcomes. So in all these points, we'll see that their trial is as per the guidelines. Other things also we have to see about the allocation, implementation, blinding, which statistical method was used, and the results, okay, in which we'll see the participant flow, recruitment, baseline data, number analyzed, and in the last discussion with and whether the trial was registered and a protocol was available which can be assessed, and whether the funding source is being mentioned. So when I saw these guidelines and I read their paper, so almost 100 upon 100 everything was followed. There are few things which we will ask sir because he is here. Okay, so And if you have any questions, please write in the chat box. Moderator Harshal will direct the questions to sir at the end of my presentation. Abstract, when I read in the abstract, we have to see whether identification as RCT is there and structured summary of the trial design, method, result, and conclusion. So when we read their abstract, all this check has been checked and it's there on point. In the introduction, what do we need to see is the scientific background and explanation of rationale is there or not, or specific objective or hypothesis is explained or not. So in their introduction, it was there. It says that ovarian responsiveness to gonadotropin stimulation has important implication for the success of IVF. Both antral follicle count and serum AMH are good predictors of ovarian response during IVF. Sonographic measurement of AFC is available immediately in most IVF center and is not lab dependent. However, the counting of antral follicle is operator dependent and is also influenced by the resolution of the probe and machine. AMH has the advantage of having less intra and intercycle variation and its determination not being operator dependent. However, it has an additional cost and there has been no standardization of AMH values measured by different assay methods available. So in this introduction, they have mentioned the background, explanation of the rationale, and specific objectives which we are looking for. To compare the proportion of women having a desired ovarian response following ovarian stimulation when gonadotropin dosing was based on AFC versus AMH in women undergoing IVF using antagonist protocol. So in the aim itself, we know it is an important study, because if we get to know that the response is equivalent, whether we take into consideration antral follicle count or CMH, AMH levels, it is going to affect our practice, day-to-day practice, because it will make the cost effectiveness better for the patient. We don't have to rely on the AMH. So this study is clinically important to implicate in our practice, but we do have to see that whether the study was done with all the parameters taken into account, whether there was any bias, and how the study was done. So those are the points which we are actually seeing one by one. So in the methods, we have to see trial design, description of the trial design which was given, and participants, interventions, outcome, and sample size. So has this study covered all these points? So how did they calculate the sample size? For the sample size calculation, they said, according to their center's record, about 50% of the patient had the desired ovarian response when antral follicle count was used to determine the gonadotropin dosing. So they assumed that increase in the AMH group to 70% achieving the desired ovarian response was clinically meaningful. A minimum of 93 women per group would be required to demonstrate a significant difference between the AMH and AFC with 80% power and type 1 error of 0.05. So they needed around, to allow for dropouts, they took a total of 200 women, that is 100 per group were recruited. So this is how they calculated the sample size. In the methods, they have explained that in the inclusion criteria, the women who were undergoing first IVF cycle, and the exclusion criteria were BMI more than 30, repeated IVF cycles, donor cycles, and undergoing pre-implantation genetic diagnosis. So these were the excluded people. Initial gonadotropin dose was adjusted according to AMH or AFC. So they have clearly mentioned the inclusion criteria, exclusion criteria, and how the initial gonadotropin dose was mentioned. How did they do the randomization? They have done randomization by block randomization. That is, they have taken a block of 10 patients. First to 10 patients, protocol A was followed, then 11 to 20B, then 21 to 30. Like this 10 computer generated block randomization they have used. Now, how the patients randomized to AFC and AMH protocol to decide the initial gonadotropin dose. How did they divide it? When the antral follicle count was less than 5, 5 to 15, and more than 15. In these three categories, they have taken the doses as gonadotropin 300, 225 to 150. And corresponding to this AMH levels, they have taken less than 1, 1 to 3.3, and more than 3.3. So in their own departmental study, they have seen how they can correlate the AFC with the AMH. So by those grounds, they have taken these cutoffs as less than 5 to 15, 15, and counterpart AMH as less than 1 to 3.3, and more than 3.3. So, in the preceding cycle, like this cycle, they have checked the AFC in 100 patients, checked the AMH in 100 patients. Then they have put the patients on pill from 12 to 21 days. And next to that cycle, when the patient has come for IVF, they have given the dosage based on this AFC to 100 patient and that AMH to 100 patient of the previous cycle. In between, one cycle of pills was there, but so some down regulation will be there. So not the present cycle values they are taking, they had taken of the previous cycle only. Okay. And those were titrated only once. Malab, they have decided the dose and they have followed the protocol. Then they have fixed protocol. They decided the dose on the basis of AFC AMH. Then they have given that dose from the 6th day they have given the antagonist, and on the 8th day they have adjusted the dose. How did they adjust the dose? If they are finding hyperstimulation is there, they have reduced the dose by 75. If there was hypo response, then they have increased the dose by 75. So only one time dose adjustment they have done on the day 8th. Primary outcome of their study was the proportion of women having a desired ovarian response. So this is what they are looking at the primarily. And desired ovarian response, which they defined, was retrieve oocyte more than 6 but less than 14. So this is something they were aiming at. Secondary outcomes were recruitment for gonadotropin, requirement for gonadotropin dose change. Were there any requirements? Total number retrieved oocytes, and follicular output rate. That is the count of dominant follicles more than 16 per AFC. And we did have planned subgroup analysis also for AFC more than 5 and less than 5. The methods which they used to compare between the group comparison, they perform using chi-square test and Mann-Whitney U-test for categorical and continuous variable respectively, and correlation between the values in the pre-treatment cycle and those in the ovarian stimulation cycle for AFC AMH was evaluated using Spearman correlation coefficient. Concordance in the AFC and AMH categorization between the pre-treatment cycle and ovarian stimulation cycle, and concordance between categorization of by AFC and that AMH in the pre-treatment cycle was assessed using Cohen's kappa. So this statistical analysis on both intention to treat and per protocol basis were performed using IBM SPSS statistics version 24 software. So this is the statistics bit which they had used for this study. When we look at the result, just look at this table, which is just like a consort guideline. They enrolled, they took women assessed for eligibility 1,137. They excluded 937 women, and 546 did not meet inclusion criteria. 214 declined to participate, 165 joined other study, and there was language barrier in 12. So out of these 100 women, they randomized 100 to AFC group and 100 to the AMH group. So this is how the allocation was done. It was done by a nurse, and this study was blinded to the patient and even to the doctors who are seeing these patients. So it's a double blind study. And this in these 100, cycle was cancelled in 2. So finally, per protocol analysis was done for 96 patients. Okay, 2 did not start and 2 cancelled. In the 100 of AMH group, again 2 cancelled and 5 deviated from the protocol. So total per protocol analysis was done for 93. So no difference were found in the background demographical or clinical characteristic between the AFC and AMH group. So they have ruled out that also, that they are saying that they were the similar clinical and demographic characteristic between both the groups. So when we look at these results, desired ovarian response achieved in AFC group 54 and AMH group 49, p-value is 0.49. So there is no difference in the primary outcome. So this was the study which was aiming to find this, and they said there's no difference. So it will add to our clinical practice that we can rely on AFC as much as on AMH if we follow this study. Gonadotropin dose adjustment, they said increased need for dose adjustment, in fact, in the AMH group. Increased gonadotropin dose in the AMH group. Lower serum peak estradiol concentration in the AMH group. So though they said that more dose is required there and more days are required, but serum peak estradiol level was lower in the AMH group. And if we compare the other things, ongoing pregnancy rate and all was similar. So there is no difference between the pregnancy achieved or ongoing pregnancy rate. Similar number of transferred embryos, OHSS cases, clinical and ongoing pregnancy rate. So for any unit, we are working for a clinical pregnancy rate, ongoing pregnancy rate. So they say if you base your protocol on AFC or AMH, your primary outcome is also same and your clinical pregnancy rate is also same. Then they have done this classifying the AFC into low, normal or high. There was moderate concordance between AFC categorization measurement in the pre-treatment versus the stimulation cycle. Similarly, in AMH, when they have classified into low, normal or high, there was moderate concordance between the AMH categorization measured in the pre-treatment versus the stimulation cycle. So concordance between categorization based on AFC and on AMH in the pre-treatment cycle was observed in 73.5%, whereas in the remaining 26% patient, there was discordance if their dosing regimens was based on the alternative unassigned parameter. So this bit also, I would like Dr. Lee to explain us in more detail when we get into discussion with him. This slide, Dr. Lee, I would like you to throw some light later. The results show there was no significant difference in the proportion of women achieving the desired ovarian response. Findings are in agreement with those of the previous meta-analysis using ROC characteristic curves prediction models, according to which both AFC and AMH had comparable performance. So they have compared such studies have been done before also, and they have taken into account those studies as well. The main strength of this study is they say that it is the first randomized double-blind trial. So this is what they have claimed, which compares the use of AFC versus serum AMH for the determination of this. And they say the ovarian response is often subject to many confounding factors, and controlling for these can be achieved only by randomized study design. Limitation, however, is that oral contraceptive priming was used to program the treatment cycle in our center, which could have altered the ovarian response or biomarkers used for its prediction. So they have mentioned the strength and limitations of their study as well. And when they compare, they have done the comparison with other study in which they have compared with the Lan et al. Study, which had similar findings, but it was used post-agonist protocol, and they had not done the double blinding. This study was, last bit is that whether the trial was registered, registration number, name of the trial, and can the trial be assessed, and source of funding. So this trial is also registered and the number is there. And they have mentioned the study was supported by research grant from a small project funding. So these details are also provided. So few things which I wanted to ask Dr. Lee was, the pre-estradiol concentration were lower in the AMH group despite receiving a higher total dose of gonadotropin. So what are the possible reasons for this, and would it affect the interpretation of findings? AFC and AMH differed from randomization to treatment cycle. In which way this would bias the results? And what are the alternatives to block randomization, and is it possible for randomization methods to influence the results in RCT? Thank you for the patient hearing. I am done with my presentation. So now we can have the questions from the chat box and the questions which I have put to Dr. Lee.
Thank you, Shweta. It was a nice presentation, excellent presentation, very well presented. I am sure Dr. Lee must be happy that his article is read in so much detail by her and presented with nitty-gritty. So yes, Dr. Lee, please answer the questions which Shweta has put forward to you, or any inputs or more insight into the paper you want to give us.
Okay, thank you very much, Dr. Chia, for this very nice presentation of our paper and the very thorough the interpretation of the findings from our work. Yep. So thanks very much for inviting me to join this very wonderful journal club. So for the first question, is regarding the apparently lower response in the AMH group compared with the AFC group. Well, we are not too sure whether this is because AMH is actually underestimating the event response, right? This is one of the explanations that can be underlying this sort of findings, but this can also be a chance finding, and we have no way to prove that in our study for the time being. Basically, for the two groups, actually, as you mentioned, for the AMH group, we use the cutoffs of 1 and also 3.3. And for the AFC group, we use the 6 and 15. So basically, about 5 and 15. So basically, the cutoff of 1, according to our regression curve within our unit, right? This is corresponding to an entropy count of 5. Whereas for the AMH of 3.3, this is corresponding to the entropy count of 15. Yep. So the cutoffs for the two grouping actually has been determined based on our in-house regression curve. So supposedly, I think the two groups should correspond in terms of the cutoffs. Yep. So we're not too sure about the reason for the slight difference in the event response. And yet, I think for the primary outcome, the percentage of patients achieving the desired response shows no significant difference. So this is for the first question. Second question, sorry, what was the second question? Can you repeat the second question again? Sorry.
Yes, I'll just 1 second. I'll just read through it. Second question was what are the alternatives to block randomization and is it possible for randomization method to influence the results in RCT?
Yeah, that is that question. Now for the randomization, I think I'm sorry, I might have not explained it too clearly in the paper. Actually, for the block randomization, this is not what, as you mentioned, that the first patient is a group A, first 10 patients group A, second 10 patients group B. Actually, this is a block of 10. So within the block, 5 group A, 5 group B in a random order, right? So this is what block randomization meant. Yep. So we have this block design because we like to ensure that we won't have all the group A's is concentrated towards the end of the study, whereas the other group B will be the beginning of the study. Okay, so this may induce a time effect. So basically, this is just to make the randomization more even out throughout the study. Yep. So this is what we meant by the block randomization. So yeah, between each block of 10, then there are 5 in group A and 5 with group B in a random order.
Okay, sir.
Yep.
And AFC and AMH differed from randomization to treatment cycle. In which way this would bias the results? Because you had given the pills in the intermediate cycle.
Oh yeah, yeah. For the pills, because that was our unit policies that we used the pill to schedule the cycles. Yeah, so we addressed that in our limitation that it might have
okay.
Actually both biomarkers, and indeed in our paper we also mentioned that if you compare the pre-treatment cycle and the treatment cycle, actually both entropy count and antirenin hormone did drop after the CUC priming. Yeah. But you have to base on the pre-treatment cycle one for the dosing actually, because in most of the units I think there there will be problem that we don't have the same day availability of the image result. Yeah. So that's why for this AFC image, in a practical setting, mostly the image should be measured in the pre-treatment cycle, where rather than on the day of starting the stimulation. So that's why in our studies, we also based on the pre-treatment cycle image or AFC to decide on the dosing. Yeah. Although for the,
yeah.
for the categorization, as we mentioned in the paper, if you look at the categorization based on pre-treatment parameter or the treatment cycle parameters, actually the concordance is acceptable, I think.
You have written that you have adjusted the dose only once on the day 8th of the cycle.
Mm-hmm.
And then you have done the step down as well as the step up.
Yeah.
Yeah. So this is routinely your practice which you do?
This was the routine practice in our unit at that time.
Okay.
Yeah, but now I think we have changed our the routine protocol a little bit. So nowadays we don't step down anymore because now we have the antagonist protocol. We can use the agonist trigger in case you over response, and we can sleep more. So I think in the modern day, the modern protocol, the risk of HSS is pretty low. So we have a abundant such practice to step down.
Okay, that's what I was just wondering.
Yeah.
Yeah. Okay. Anybody has any questions, Harshal, in the chat box?
No, there's no question over here. Anyone has any question?
No, Dr. Sandhya Khare was raising hand and somebody else also. But nothing is there in the chat box.
Yes, ma'am.
Basir ma'am, are you there? I think so.
Yes, ma'am.
Dr. Meenu or anybody is there?
I'm there, Shweta, very much. I think it was a nice discussion. It was a
I
very
he's
nice
about to go. So
yeah. So thank you, Dr. Lee, for being here and giving your inputs. I think paper was very well written. I mean, it was like according to like everything Shweta has explained. All details were there. So I think there were not many questions. It was self-explanatory paper. And I think it is helpful in the clinical practice to correlate AFC and AMs and enteral follicle count and AMH levels. I think we really in the SAFOG region, especially we are looking at doing the infertility practices with a lesser cost, like rather than adding on to doing the endocrine estimation as well as sonography. I think we have to really follow and develop one protocol where we can benefit our population by not putting a lot of economic burden on them. So thank you very much, Dr. Lee.
Thanks very much for inviting me once again. Yeah, so it's very nice to meet you all.
Thank you. We will interact many more platforms. So thank you. Yep.
Thank you, Dr. Thank you. Thanks a lot.
Thank you.
Thank you.
Thank you. Thank you, Archana Vase ma'am, Shweta ma'am, and Dr. Raymond Lee sir. Let's move forward to our next session. The topic of our next session is first trimester pre-eclampsia screening and prediction. For that, I would like to introduce the mentor, Dr. Shaila Jabal ma'am. Dr. Shaila Jabal ma'am is a social activist, medical journalist. Ma'am is an associated professor at RMRI Bareilly, founder president of Society of Menstrual Disorders, chief editor of Journal of Reproduction and Menstrual Disorders, director of Menstrual Health Science at Pinkish Foundation, North Zone in charge of Young Talent Promotion Committee FOXY, coordinator Endocrinology Committee FOXY, MEU coordinator. Man has 44 publications in international and national journals, contributed to 7 chapters in FOXY Focus and other books, peer reviewer in 4 international journals. Ma'am is a FOXY Leader of Tomorrow. Ma'am has many awards. One of the FOXY Leader of Tomorrow Awards, FOXY Pack Awards, Awards of Honor by WHO, Awards of Excellence, and first prize in paper presentation and adolescent international conference. Presented papers, lectures in many national and international conferences. Thank you, ma'am, for being here. Along with that, I would like to introduce to the next speaker, Dr. Dimi Modisha, MS OBGYN Gold Medalist, DNB. She is a proud alumni of Maharaji Sayajirao University, Baroda, has done both MBBS and MS with gold medal over there. She has received formal training in advanced ultrasound in Mumbai, alternate birthing procedure technique and CT training at Fernandez Hospital, Hyderabad. Proud member of FOXI and ISAR. SAFOG State Conference Rotary Club Trophy for the best debate on robotics and laparoscopic hysterectomy. Gold medal at paper presentation at FOXI Conference on 90. Currently practicing under the guidance of Dr. Dheeraj Gada sir, she aims to pursue her career in holistic maternity care. It's over to Dr. MP.
Thank you, Dr. Harshal sir. I would like to start the screen sharing.
Is Dr. Shahala also here? Harshal, while Dimpy is presenting, just connect with Shahala and because what are her points and things so we can take her inputs. Yeah, Dimpy, over to you.
Yes. Is my screen visible?
Yes.
Okay. So good evening, one and all. It is a pleasant feeling to be presenting a very extensively prepared article on a very important topic, pre-eclampsia. First of all, I'm very honored by the generous presence of Dr. Rohana sir, who is President SAFOG, and Chairperson Dr. Atit Patel. I would really like to extend my gratitude to Dr. Archana Vasel ma'am, who selected my presentation, and I'm very happy that she arranged such a scientific platform for people like us who are young and want to show our presence and learn something new. I would like to extend my thanks to Dr. Shaila Jamal ma'am. Under her kind supervision, she just helped me walk through the article, which is very extensively prepared, and she literally helped me through the whole way out. So now I would like to just start the presentation. The presentation is visible, right?
Yes.
Okay.
It is visible.
Yes.
And the author of the paper today, Leona, is celebrating her birthday. So
yes.
She's not here. We did connected with her, but she couldn't be here.
Yes, ma'am. So the selected article for the presentation is First Trimester Pre-Eclampsia Screening and Prediction. It is an expert review article by 3 authors, Pia Chen Seng Thong, Daljit Singh Sahota, and Dr. Leona C. Poon. They all hail from Department of Obstetrics and Gynecology, Prince of Wales Hospital from Hong Kong. The article was received on 2nd June 2020, and it was available online from July 2020. The version of record is available from 15 Feb 2022. Now, critically appraising the title is very concise, very clear. It indicates the prior focus and the objective of the study. It does not actually define the study outcome, and there is no undue sensationalization.
Full screen. Put it full screen. Full screen.
Yeah, I'm trying to. Yeah. Thank you, ma'am. Okay, so moving forward, this is an expert review article. To throw some light on this topic, expert review article is a kind of article which provides concise reviews on the topic in which the author has an expertise. It is an evidence-based article. The goal of the article is that it should be a concise update and it should be limited to around 3,500 words. It is published in AJOG, the American Journal of Obstetrics and Gynecology. This journal does not need any introduction. It is famously known as the Gray Journal. It is an index journal, highly peer-reviewed. It has a high impact factor of 8.661, and the acceptance rate is of around 12%. Critically appraising journal, the journal is reliable, indexing sites are easily available, it has an easy accessibility of articles, it is monthly published, and around 295 articles are published per year in the journal with a very short review time and a publication time. To throw some light on peer review processing means that the author submits the article is assessed by the editor, then it is sent to the reviewers, and a group of reviewers will assess whatever is submitted, and then they might reject and send it back to the author. So when it is an extensively reviewed process, the article becomes very authentic. Throwing some information on author Pia Chemsaithong, Daljit Singh Sahota, and the corresponding author, Dr. Leona C. Poon, they all hail from Hong Kong. There are 3 authors in the article, but the corresponding author, Dr. Leona C. Poon, she has around 253 publications to her name, and she holds special interest and expertise in the field of pre-eclampsia. Now, moving on to the abstract. As you can see, the abstract says that the pre-eclampsia is a major cause of maternal and perinatal morbidity and mortality. The evidence suggests that a low-dose aspirin initiated before 16 weeks of gestation will significantly reduce the rate of preterm pre-eclampsia. identifies the pregnant women at risk of developing the preeclampsia, thus allowing timely therapeutic intervention. Now, ACOG and NICE have proposed various screening tests, each risk factor as a separate screening test. The evidence says that the NICE achieves a detection rate of only 41% for preterm preeclampsia and 34% for term preeclampsia at a 10% FPR. Whereas ACOG achieves a detection rate of only 5% for preterm and 2% for term preeclampsia. And other prediction models have not undergone the external validation. So the FMF predictor model was introduced, which has undergone excessive external validation, and it involves three factors. One is the maternal factor. Second is the mean arterial pressure, that is a biomarker. The uterine artery pulsatility index, which is an imaging modality, and the serum placental growth factor, PLGF. FMF predictor model has achieved a detection rate of around 90% for early and 75% for preterm preeclampsia. And it reduces the rate of preterm preeclampsia by 62% according to the model. The number needed to screen to prevent one case of preterm preeclampsia by the FMF model is 250. And to establish a standardized protocol for biomarker measurements and regular biomarker quality assessment is the goal of the model. And the quality assessment by the tool is done using two statistical analytical methods. One is the cumulative sum method and target plot method. Now, critically appraising the abstract gives the assumption of full article. You might have seen that the abstract is very unstructured, but it is because it is an expert review article. And an expert review article does not have any subcategories. It has just one paragraph, because this will compel the reader to read through the entire article. The article is in excess of length because it is a very extensive article, and the information which is extracted from the abstract matches the full article. Moving on to introduction, we all know that preeclampsia is a multisystemic disorder, develops after 20 weeks of gestation, and it affects 2 to 8% of pregnant women. The adverse effects are not unknown. Now, ISSHP has subclassified the preeclampsia as per the gestational age of delivery. So when an early onset, that is the delivery is at less than 34 weeks of gestation, and a preterm preeclampsia, that is the delivery less than 37 weeks of gestation, they have more adverse outcome in terms of maternal and perinatal outcome compared to a late onset or a term preeclampsia. So, moving on to the pathophysiology of preeclampsia, we all know that the stage 1 is the stage of shallow placentation, and it can be because of the maternal factors like hypertension, diabetes, APLA, or because of the immunological factors, or because of genetic factors like trisomy 30. So, stage 1 usually occurs in the first trimester of pregnancy, and this is the golden period, my friends, to understand the subclinical phase and pick up the disease. Stage 1, the stage of shallow placentation, moves on to the stage 2, that is the stage of oxidative stress. So stage 1 creates a window of opportunity, and when this period is recognized and a low dose aspirin of 150 milligram daily is administered from less than 13 weeks till 36 weeks, then it has shown to reduce the rate of preterm preeclampsia. The critical appraisal of introduction, very logically presented, pathophysiology is well explained, very meaningful, built on literature review, and clearly states the research hypothesis and objective. The objective is 4. First, the article summarizes what are the existing literature on different methods of the prediction. Secondly, the recommendations for different professional organizations, because there are many. Third, quality assessment, and fourth, the clinical implementation. The design that the author has used is logistic regression analysis, and it was done in a university-affiliated tertiary hospital. Now, we all know maternal history are very important. They are one of the bigger main point of the model. 2 remarkable risk factors. One is history of preeclampsia, which has a relative risk of 8.4, and secondly, chronic hypertension. These are the 2 remarkable risk factors which become a very important highlight. And other risk factors like nulliparity, advanced maternal age, chronic kidney disease, pre-pregnancy BMI more than 30, and pre-gestational diabetes. So when we look into different studies by different models like ACOG, NICE, SOGC, SOMANS, and WHO, they all have provided a checklist of risk factors. And according to those checklists, they have administered the aspirin dose. Some administer dose of 81 and some administer dose of 100 to 150. Now, NICE achieves a detection rate of only 41% for preterm and 34% for term, and ACOG only 5% for preterm and 2% for term. And you can look at into this very clear graph that at a 20% false positive rate, the detection rate by the FMF triple test is around 80 to 90%, which is very high. So the author recommends using this model. The first trimester screening study of preeclampsia based on maternal history through logistic regression analysis states that whenever a woman is of Afro-Caribbean racial origin or has a history of preeclampsia, or is a chronic hypertension, has conceived with ovulation induction, or has a very advanced maternal age, then they are at the increased risk of early onset preeclampsia, that is before 34 weeks. And when the BMI is high, family history is there, or is the history of preeclampsia, or if she's Afro-Caribbean again, then they are at increased risk of late onset preeclampsia. But we are actually here focusing only on the early onset preeclampsia. Now, logistic regression analysis, a very, very difficult term to listen to, but actually it is not that difficult. Logistic regression analysis basically uses the biomarkers, the mean arterial pressure, the use of blood PLGF. So they use biomarker values and then they transform into the multiples of median. Now, calculation of MOM is not a headache. It is already pre-calculated by computer, but the advantage of using logistic regression analysis is it combines the maternal factors with the biophysical and the biochemical. So uterine artery PI, mean arterial pressure, and PLGF, everything is combined with the maternal factors and a result is obtained. Just one drawback, that there is a binary outcome. It means that either it is a yes or a no. Okay, not okay. So then we move on to Bayes' theorem, which is again described by the author that Bayes' theorem is a better technique. Because Bayes' theorem helps us in assessment of individual patient specific risk of preeclampsia. And you can even change the markers if needed for a particular patient. So new markers can be added. And this approach assumes that if the pregnancy were to continue indefinitely, not terminated at 40 weeks, if a pregnancy goes on indefinitely, all the women will experience preeclampsia. So depending on the competition on the between delivery before the development of preeclampsia or after the development of preeclampsia, that is detected by Bayes' theorem. You can look into the graph here. Like you can see, the patient who are at the low risk, they will develop preeclampsia maybe at 56 to 60 weeks of gestation, which is not possible, but it is a theory. And the patient who are at high risk might develop even before 40 weeks. So this is what is studied by the Bayes' theorem or the competing risk model. Systematic review has indicated that only 4 first trimester models are good and with a C statistics of more than 0.8. And the model developed by the author Poon et al. Was the only model with successful external validation in more than one population. So these are the summary of 4 good first trimester preeclampsia model. And I would like to show you that the Poon model by Dr. Poon in 2010 for preterm preeclampsia less than 34 weeks and more than 34 weeks. They both had a negative predictive value of 99.6 and 98.7, which is quite high. And the detection rate was also very good. So both the models were studied extensively in more than one population. Like you can see, it was studied in United States and also in Australia. Now, the major limitation, which has been described by the author, that existing prediction models are only few of them have undergone external validation and they are prone to overfitting. They overestimate the screening performance. So the FMF prediction model, it was actually started in and around London and it was studied in various racial groups. Around 7797 pregnancies were taken in which 2% developed preeclampsia, and it used logistic regression analysis, was done between 11 to 13 weeks of gestation, and it achieved a detection rate of 93% for early onset and 36% for late onset. So here again, I would like to show you the graph that when you take a FMF triple test, then you achieve a detection rate of 90% for early onset preeclampsia compared to only using a maternal factor. So when you combine these 3 things, it definitely improves the detection rate. The models is validated in various centers. And this is a very crisp timeline of different models that have been developed over the time, so since 2009 to 2019. And of that, FMF triple test is widely used. Now, coming to the biomarkers, we have used 2 biomarkers, mean arterial pressure and uterine artery PI. Mean arterial pressure, it has to be measured. This diagram was, this photograph was very clearly given in the article that you have to measure it in this way. 2 arms simultaneously, you have to measure in both the arms with the automated blood pressure device, and you have to take at least 4 measurements. Now, the uterine artery PI, since it is an imaging science committee presentation, so I would like to throw some light on this topic, that uterine artery PI, very, very commonly used in South Asian countries now. According to the Fetal Medicine Foundation, when you use a trans-abdominal ultrasound with the sagittal section of the uterus, you locate the internal cervical os, and then you put the transducer in the midline till to the lateral side of the cervix, you will find the uterine arteries. Now, the color Doppler is put, pulse wave Doppler is put, and you take at least 3 consecutive waveforms. So this is the uterine artery PI that the graph should be. It's a C-shaped vessel that you can see lighting up near the internal os, and this is the way that should be obtained. Now, very important, the MOM. So what is the MOM that should be obtained? So if the uterine artery PI value is somewhere between 0.9 to 1.05 MOM, it is an ideal range. And if it is 0.9 to 1.1, then it becomes acceptable. And in this case, 97.6% becomes the detection rate. Now, biochemical markers, there are many like PLGF, PAPPA, SFLT1, but we focus on PLGF in our case. And authors have reported that the Asian population, the MOM value of MAP and PLGF is 4 to 11% lower than in the European population. So that is why a multi-centric or multiple populations are needed to be studied, and that's what the author has done. So critically appraising the material and method, the patients are clearly defined. All the exclusion criteria is not that well defined. The researcher, location, and source is well defined. Time is not clearly defined because it involves a long period of time in multicentric studies. Ultrasound operators require specific training. Frequent calibration of the analysis is done, and the biophysical markers are susceptible to considerable variability in these measurements. That is clearly mentioned. Now coming to quality assessment, a little boring and a difficult topic to apprehend in a webinar, but I would like to throw some light that QSUM, that is the cumulative sum and target plot. This too is very, very clearly explained by the author in the form of diagram and the chart. So as you can see, when you take a cumulative sum, you will see even a slight variation, even a small shift can be easily seen through the cumulative sum chart. Target plotting, another method to analyze. In this, the central tendency is plotted on the x-axis and the dispersion is plotted on the y-axis. And the inner square box, yellow, corresponds to the central tendency and the dispersion that is within the 5% of the expected MOM and SD. And acceptable performance is when it is within the 10% of the expected. So you can see where the charting is done. Comparison of QSUM and target plot. QSUM is a sensitive method. The point of shift can be easily visualized, but it is complicated. Target plot, its insensitivity is there, but the requirement of large data sets. So critically appraising the statistical analysis, the advantage of logistic regression analysis is that it can be used to combine the maternal factors with biochemical and biophysical factors, and the statistical tests were data appropriate. Now, quickly moving to the clinical implementation, we know that clinical implementation is must, and the author has very, very nicely described it. She has said that collection of maternal data, history, and measurements by a trained staff is necessary. Transcribing the data into the risk calculator with a regular review is necessary. Measurement of mean arterial pressure is to be taken by healthcare assistants. Measurement of uterine artery PI is to be taken by same ultrasound operators and machine and not with a variation. Measurement of serum PLGF can be undertaken on the same blood sample and by the same automated analyzers for the PAPA, which is used for the Down syndrome screening. Now, number needed to screen, a very difficult word to listen to, but it's actually very simple. It is a tool for measuring the screening benefits. Since we are screening here, we need to see how efficient the screening tool is. So according to the ASPIR trial, the famous aspirin trial, the NNS based on the first trimester combined test tells that to prevent one case of all preeclampsia, you need to screen 143 patients. And to prevent one case of preterm preeclampsia, you need to screen 250 patients, which is quite okay because this is equivalent to NNS for screening the GBS colonization. And it is even way lower than NNS for breast cancer by mammography or lung cancer by CTP or colon cancer by colonoscopy. Now, talking about a low resource setting in which the South Asian countries fall, screening of preeclampsia using maternal factors and biomarkers have been developed exclusively in high-income countries. So tests such as uterine artery PI and PLGF are not readily available in the primary healthcare settings in low resource countries. Future studies, as we know, there is, because preeclampsia is very complex in nature, so there's no single predictive marker. You need a combination of marker. And low-dose aspirin is not effective in preventing the term preeclampsia. Mind it, it is just useful for preterm preeclampsia. So the reason is very clear. First of all, there's suboptimal screening performance for the first trimester algorithm. And secondly, the hypothesis states that the term preeclampsia is not a placenta-mediated complication. And therefore, aspirin does not help. So this is clearly stated by the author. Now, I would like to conclude by saying that, which is clearly said by the author, that the traditional approach by the NICE or ACOG, which is a checklist method, that is a very limited predictive performance. So best way to identify the high risk group is using Bayes' theorem. And aspirin should be started before 16 weeks of gestation, and screening should be done during the first trimester of pregnancy. Well, I would like to critically appraise the conclusion by saying three things. It was totally based on objective. The conclusion was very short and it directly answers the research hypothesis. And it does not, create a new buzz of new hypothesis. The references were well cited. Most of the references were available on PubMed, and it was done in Vancouver styling. There was direct link of the cited reference available, and this was reliable. Now, the strengths of the study, according to me, was that the keywords were well defined. Information was provided in a very sequential manner. Training was given to the data collector and the ultrasound expert. Sample size was much larger than all the previous studies, and it focuses on the external validation of the proposed model. Methodology was very well explained. The pictorial representation, chart, graphs made the article very, very interesting to read to, and it was supported by standard analytical tests. Weakness of the study, it was a little lengthy. Few statistical analyses were very complex to understand, and the inclusion and exclusion criteria was not well defined. So I would like to complete my presentation. Thank you for your kind attention. I would really like to hand over to the chairperson and mentor, Dr. Shaila Jamal.
Thank you. Before Dr. Basir takes it over, congratulations, first of all, to Dr. Archana Basir, ma'am, for organizing such an elaborate the JC platform, especially for the youngsters. And we were already blessed to have had kind words by Rohana sir. And Dimpy, what a presentation. What a presentation. You were so confident, elaborate, and beautiful in your careful selection of words also. And yes, it was meticulous choice, and the article had all the weight and worth to be discussed on such a prestigious platform. I just wish that Dr. Poon should have been here to witness how beautifully and how elaborately her article was discussed and appraised. So in the end, I would like to say if there are any questions, we are open for discussion, especially for the statistical part, because Dimpy and I had to work a lot. We were also going through it quite a number of times. Okay, what is this? So, and yes, in the end, I would like to thank Dr. Shweta also for her kind support throughout. And I hand it over back to Dr. Basir and Dr. Shweta. Thank you, Dimpy, and congratulations.
Thank you, ma'am. Thank you, ma'am, for the guidance throughout.
Okay. Harshal, Dr. Basir had an emergency and she had to leave.
Wonderful. Yes, ma'am. It was a wonderful presentation, and I will like the last vote of thanks by Dr. Shweta Kaul, ma'am, and thank you, Shaila Jamal, ma'am, for joining us. Shweta, ma'am, please.
Okay. Thank you, everybody. Dr. Basir had some emergency, so she had to leave in between. I would like to thank, first of all, Dr. Rohana sir for agreeing and being our guest of honor, and even the apology. Dr. Rohana, good evening, sir. Dr. Basir had some emergency, I think so she had to leave. So she has asked me to express our gratitude towards your presence, and despite odd situations which we all are facing nowadays, and especially at your country, you agreed and you have given your time and presence here. It means a lot, sir. Thanks a lot from all of us.
Thank you. Thank you.
And we look forward to such more sessions every month. Every month, last Sunday, we have blocked it for Journal Club, sir.
Okay,
so
fine.
next July, last Sunday, I think so it's 31st July. So we'll have another one and we'll again contact you, sir. Okay, thank you, sir. And then I would like to thank Shehla for being mentor to Dimpy, and thank you, Dimpy and Harshal, for an excellent presentation, Dimpy, and Harshal for doing a good master of ceremony. And I would like to thank the people. I'd like to thank Farmed people, most important, Mr. Sudeep and team. They have been with us since day one for sending the mail, for all the logistic support. So thank you, Mr. Sudeep, if you are there.
Thanks a lot, madam.
Thank you. Thanks a lot. It was very kind of you and you have been excellent. So with that, I think so we end this session. Okay.
Thank you, ma'am.
Thank you.
Everyone.
Thank you to all the participants and panelists for being here. Thank you.
Close the session.